Good morning, everyone, and welcome to today's event, Best Practices for AFib Management in the Emergency Department. Before we get started, I'd like to go over a few items so you know how to participate in today's event. This webinar is being recorded and will be sent via email within 24 hours. You will have the opportunity to submit text questions by typing them into the questions pane of the control panel. You may send your questions in at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. And finally, if you experience any technical issues during the presentation, most can be resolved by refreshing your browser. If your issue is not resolved following the refresh, please refer to the GoToWebinar customer service team whose contact information can be found in your webinar confirmation email. I'd now like to introduce our speakers from Cone Health today. We have Dr. James Alred, Director of EP Services in AFib Clinics, Amber Seiler, Arrhythmia Services Coordinator, and Dr. Ankit Nanavati, ED Physician and AFib Champion. I'll now hand it over to Dr. James Alred for today's presentation.
Thank you so much, Anastasia. It's really great to have the opportunity to be with you today. Thank you all for attending our webinar. We're excited to share our Cone Health experience with you, looking at our emergency department's role in managing patients with atrial fibrillation. Here are our disclosures as we begin. So our objectives. Today we want to think about options for managing patients with atrial fibrillation, looking at a comprehensive approach to patients with atrial fibrillation, and discussing the importance of our emergency department and collaborating with cardiology to create a comprehensive AFib center. And then we'll also look at the operational impact of a collaborative ER protocol at Cone Health. So we know that there are a lot of patients who have atrial fibrillation. Everybody on this call is aware of that. And we expect that this will continue to double over the next 25 years, such that atrial fibrillation right now is the most common presentation for patients when they come to our emergency department as far as an arrhythmia goes. And there are more than 467,000 admissions every year for patients with a primary diagnosis of atrial fibrillation. I want to introduce Dr. Ankit Nanavati. He's our emergency room champion for atrial fibrillation at Cone Health. Dr. Nanavati, when patients present with atrial fibrillation to the emergency department, what kind of things are they complaining of? What kind of symptoms do they have? And what do you see typically?
Thank you, Dr. Aldred. So again, thanks for the opportunity to come and speak with our cardiology and emergency colleagues that are tuned in. Most often our patients come in with a lot of non-specific symptoms. They will come in saying, I've been just feeling weak for the last few hours. I've been having shortness of breath with exertion. They hardly complain of palpitations, and often chest pain is also not a driving complaint for them. So a lot of dizziness. I'm feeling weaker than usual, normally when they present with those complaints, we often notice that they are in AFib with RVR, not just new onset AFib that is rate controlled.
And so when these patients present, how do you get a sense for how long their AFib has been going on? You know, one thing we think about in cardiology is that if they've been in AFib for less than 48 hours, we feel a lot better about cardioverting the patient if they're not on anticoagulation. And we'll talk about our protocol in a little bit. But when that patient presents, how do you try to get a sense for how long they've been in AFib?
So we look for acute change in their well-being. And so if the patients are able to tell us and clearly define that I was doing well 24 hours ago, I did a lot of yard work, everything was fine, and then suddenly I started feeling weak and I just felt maybe I overstretched myself or overextended myself, but this is just not going away. And so if you're able to get a very clear delineation on when the onset began, then we feel comfortable stating that perhaps the onset of AFib event was during that last 24 hours.
Thank you so much. And so when a patient presents with atrial fibrillation, we'll look in just a few minutes at our approach to that. We certainly know that there are a lot of patients across this country that have atrial fibrillation. And so My suspicion is everyone on this call frequently has the opportunity of taking care of the AFib patient, and the fact that you're here today hopefully means that you're engaged and excited about helping our AFib patient population. You know, when patients come to the emergency room, they don't always just have atrial fibrillation. They frequently have other comorbidities. You know, the majority of patients have, you know, at least 4 or more comorbidities, such as COPD or congestive heart failure, hypertension, diabetes, and the list goes on and on, prior stroke, you know, these kinds of things. And so, you know, frequently it's not just that we're managing the atrial fibrillation, but that we're managing the other comorbidities as well. But when you look at the reason that these patients are getting admitted, very frequently it is due to their atrial fibrillation. And so Dr. Nadavati, a patient presents to the emergency department with atrial fibrillation, and we think about the treatment strategy for those patients. You know, what kind of things come to mind when that patient rolls in the door, and what's your approach outside of our protocol, which we'll get to in a little bit?
Yeah, so outside of the protocol in the emergency department, our first question is this patient stable versus unstable? Of course, if they're unstable, then we take care of the resuscitation that needs to occur. But for the patients, which most patients will present in a stable disposition, we then ask, you know, whether we should follow through on rate control strategy or rhythm control strategy. And the rhythm control strategy is something that emergency departments have been talking about more so recently than they were maybe about 10 years ago. And so overarching places would go with rate control right now. And that is also in our department. If you're not sure when the onset of AFib was, if we know that the patient is in permanent AFib, if we feel like this person likely has a valvular AFib because of their comorbidities, and if we think that the underlying issue is primarily not AFib, but some other driving process like PE or atrial fibrillation, or sepsis, then we focus on rate control and then treating the underlying problem. Rhythm control is something that we have started discussing more so in our ER at Cone Health recently, especially after creation of this collaborative process that we have. And traditionally, we still focus on new onset AFib patients less than 48 hours. We're pretty aggressive and comfortable at cardioverting them in the ER. Most of our colleagues have been doing electric cardioversion, although we have a dedicated pharmacy team available and also support of our cardiology colleagues that if we wanted to ask questions about chemical cardioversion, we have that option. But most of us do choose the rapid electrical cardioversion option. And it's nice that we have a setup where we have pretty much guaranteed follow-up within our Cone system with our EP specialist in 7 days, and that was critical.
Absolutely. And, you know, so once that patient has been stabilized, rate controlled, you determine whether or not that patient is a candidate for rhythm control with cardioversion. You know, part of our protocol that we'll touch on today is a big part of the American Heart Association's quality initiative, which is stroke prevention. And so, you know, each of these patients prior to discharge would be started on anticoagulation as indicated with close follow-up. And then also in electrophysiology, a big area for us these days, you know, is the prevention of progression of the disease. And so, you know, in the past, a patient might present with AFib and then, you know, be treated at a one-time visit and not have follow-up with maybe even cardiology, much less electrophysiology. But, you know, over the last few years, what we've realized is that to prevent progression of their AFib from a paroxysmal disease to a more persistent disease, you know, to prevent fibrotic changes within the heart, atrial enlargement, and other things that cause their own set of comorbid conditions, we want to have that patient followed very closely. And so something we'll talk about today in our protocol is how these patients, after they leave the ER, land in our AFib clinic so that they can have longitudinal care to address, things like obesity and diabetes and high blood pressure, and also to try to maintain that patient's sinus rhythm long term. The study East AFNet 4 was a study this past year that showed early intervention on patients with atrial fibrillation can have lasting results for that patient. And we know that, when our patients come to the emergency department, many of them are admitted. There are a lot of patients with AFib, and there are a lot of costs in healthcare related to patients with atrial fibrillation. There's a lot of opportunity within healthcare in our AFib patient population to reduce these costs. More than half of the costs related to AFib management are inpatient costs, whether that's related to the CV related direct cost or non-cardiovascular cost. There's a huge opportunity if we can keep these patients out of the ER, keep these patients out of the hospital to help reduce cost of care to the patient, but also to our healthcare system. And I think that's very important, because when you look here at this slide, 750,000 patients are hospitalized every year with atrial fibrillation. And they don't, these patients don't have one hospitalization. When you look at Medicare patients, if you have AFib in Medicare, 61% of those patients are going to visit the ER at least once, but more than half of them are going to visit the ER at least 3 times. And so, it's all about identifying a way to manage patients appropriately, safely, but also effectively. When we think about value, it's great quality care, also at the appropriate cost for that patient. So keeping costs low, but giving great quality care to patients. And so that's what we're hoping to look at today. So when you look at hospitalization for AFib, what you see is that the average length of stay across this country is 3 days. And when we were initially putting our protocol together back in 2016, 2015, when we're really just getting started, we looked at our length of stay for patients with a primary admission diagnosis of atrial fibrillation. And just as this slide suggests, our average length of stay was 3.2 days with a range of 2 to 5 days. And so Amber Seiler's on this call. She's one of the nurse practitioners and really coordinates and helps us manage our AFib and our electrophysiology patients. Amber, during that 3-day hospitalization, what do we do for these patients?
Yeah, it's a really great question. And I think, prior to us putting this initiative together, patients came into the emergency room with symptoms and either a new or established diagnosis of AFib and rates not well controlled. And the knee jerk was to admit all of those patients. And that's exactly what we did. We admitted every single one of those patients. And so the story is the same as probably most of you on the call are familiar with, right? They come in, they get put on a heparin drip, you get put on a cardizem drip, and eventually somebody the next day or two gets around to deciding what anticoagulation they're going to be sent home with long term, and then their rates go too slow. We've got to adjust their medicines, and at the end of those 3 days, they walk out basically on the same medicines they came in on, maybe with the exception of the addition of anticoagulation. And so a real driving force whenever we started looking at our data and at this program was, do we really need to keep patients in the hospital, or is there a way that we can, again, like you said, manage them safely and effectively and avoid that hospitalization for the patient and the system?
Thank you. So exactly. So we started looking at these patients and realizing opportunity. And so we put together this protocol. This here is basically a picture of a large sign that we have posted throughout our emergency room. We took this graphic, we blew it up into a large size, and we have it in our ER. We have it in our fellows call room for cardiology. We also have it in kind of the place where our cardiologists hang out, because we wanted everyone to be familiar with this protocol. And we'll get into the protocol in just a few minutes. But back in 2015, when we started looking around at ways to do things and to way to deliver care to our ER patients with AFib better, we realized there weren't very many people that were doing this successfully or even at all. It really wasn't on people's radar screen back then. And so early on, we started our process, and that's why we're excited about sharing this with you today. And you should have access to handouts today, which will include our protocol and this exact image. And so, we would encourage you to put that together. And you say, wow, that's awful simple, James. That's just like a small flow sheet. And when we started this, we had a 13-page document that we took to our ER providers, and they said, "Are you kidding me? If we'll give you one page. AFib is one of a 1,000 things we treat, and we can't have a 13-page protocol. We need to have this streamlined." And so that's intentional and something that we'll talk about in just a minute with Dr. Nanavati. But you'd say, well, how did you get started? It was actually Dr. Nanavati who brought this to our attention. He said, "James, there's literature in the ER world going back to the 1990s that say that patients can be successfully cardioverted from atrial fibrillation in the ER. And here's another example of this is a study from 2010. The Ottawa group in Canada, they were very aggressive in putting together their early experiences with a rapid discharge of ER patients with recent onset atrial fibrillation and atrial flutter. And so, I think, everyone says, well, how are we going to get the ER involved and on board? I feel like in some ways it was harder for our cardiology colleagues to do this. But so Dr. Nanavati, talk to us a little bit about how we got started and the early conversations and collaboration, and what did that look like?
Yeah, so the early conversations, if I recall properly, it was when you had come to our service meeting and talked about atrial fibrillation and your vision of starting perhaps an AFib dedicated clinic. And I had just finished my residency. I was in Detroit, Michigan, and had the benefit of walking and talking with a lot of Canadian colleagues. And we discussed some of the changes in practice pattern. And Dr. Steele is one of the perhaps the legends of emergency departments, especially within the AFib and cardiovascular emergency front. And we had actually studied his protocol in our residency, and we had talked about how rapid cardioversion is in fact safe and pretty efficacious in most cases. And so when you had come and talked about the dedicated AFib clinic, I thought that was a great opportunity to serve our community in a different manner, and perhaps the new onset, less than 48-hour AFib patients where the knee-jerk reaction was, well, I don't know if I can get the patient follow-up. I'm not sure if I'm putting patients at higher risk of cardioembolic events. Let me just start rate control, knowing that rate control really big, that with the large AFFIRM trial showed no, it was not inferior to rhythm control. So why perhaps take that extra risk? That's what kind of the EP emergency medicine docs are thinking. And so when you presented that option to us, I thought this was an opportunity to talk about, perhaps we can be more aggressive in the ER. The willingness was there. This was perhaps a missing link, and we can create a protocol.
So how did you get your colleagues on board in the emergency department? What were some of those conversations early on?
Some of the earlier conversations were in regards to ensuring that we were doing the right thing, the safe thing, and not just focusing on the operational benefits. I'll be very honest. I think when we talk about a landmark trial like AFFIRM, which came out early in 2000, and it said, rate control is not inferior to rhythm control, and rhythm control intrinsically does carry some risk for patients. Should we be pivoting to a strategy like that, which has, yes, a lot of operational benefits, but what about on the patient side? And so we talked a lot about safety and efficacy for those patients. It also became very apparent to us in our department that boarding patients was becoming an issue. It already is an issue at a lot of urban emergency departments, but we were sheltered from it until the last maybe 5-6 years. And we look at the waiting room as a ticking time bomb. The longer the patients board in our ERs because of throughput issues on the back door, the more patients spend time in the waiting room, the more dangerous it is for them. So we looked at it kind of from a comprehensive approach. Is rhythm control going to be efficacious? Is it safe for the patients? And the evidence overwhelmingly said that it was effective in converting patients into sinus rhythm. It was in fact safe. There is some risk that comes with things like sedation, but it was a low risk event. And then having that extra link of cardiology who was cardiology team was readily available for consultation in those questionable cases was vital for us to get that buy-in from cardiology to support us in coming and assessing the patient. We just needed that, yes, we are ready, that commitment. And that was something that a lot of my EP colleagues were discussing. And then finally, follow-up. What we do in the ER is maybe a blink of an eye or snapshot of the overall comprehensive care for the AFib patients. And it was prudent for our team to ensure that our patients, if seen in the ED, had no barrier to access to the EPs in the outpatient setting if they were cardioverted and discharged.
Very good. I think that's a really nice summary of a lot of conversations that occurred over a lot of months. Another thing I think that was a big deal was the concern for, okay, if we're cardioverting these patients, what's that going to do with our ER length of stays and discharges? It's, it's really important in this day and age that patients have quick throughput through the ER. And are we going to have lots of prolonged patients sitting here waiting after cardioversion? We'll look at that data today. Amber Seiler is going to present that to us in just a couple of minutes. I do think, so here's our protocol, and I'll get Dr. Nanavati to, briefly walk us through the protocol here in a second. There are a lot of folks out there that are doing this really, really well. This is our experience, and we'll show you our data today, but that's not to say this is the only way to do it. And there are nuances that some people do differently. Some folks, for example, do have an observation unit where patients might go to be observed as part of their ER protocol for AFib management. We do not have that, so our patients are one direction or the other. They either are going to go straight home, or they're going to, because we feel they are unstable or have other issues, they're going to be admitted, maybe observation status, but not to an observation unit. And so when you look at our data, the discharge patients are going home, where, in some groups they might have stayed in a unit of some sort for a prolonged period of time. And I think there's so many different ways of doing this. But Dr. Nanavati, just briefly, and we've talked about this a lot already, but just walk us through this protocol and how you approach this patient.
Sure, James. And so, Dr. Allred, when we sat down and talked about the protocol, we really focused on the empiric data and wanted to practice evidence-based medicine. So really the protocol focuses on stable, new onset AFib patients or stable primary diagnosis AFib patients, unstable patients, and in patients who are coming in with AFib, but they have their underlying reason for being out of homeostasis is not primary cardiovascular, but things like sepsis are not included in the protocol. So focusing on those patients, if those patients are stable, and we know that the onset, and we're very confident and comfortable saying that the onset of this AFib event is less than 48 hours, then we feel comfortable cardioverting them. One area where we did make a little bit of tweak in our protocol was, again, kind of based on the evidence and empiric data of the anticoagulation use. If the patients have paroxysmal AFib and they were properly anticoagulated for at least the last 3 weeks, and most of our ED guys just remember 1 month in the back of their mind, if they've been religious with taking their medications and are well controlled on their medications for anticoagulation for over a month, then they are included in our cardioversion strategy. Now, there will always be a possibility of patients that the EP would not be 100% comfortable cardioverting, and they just need a little helping hand to look at the patient from a different perspective. And so we allow for our EPs to call cardiology, and our cardiology team is very receptive at being involved in the care of these patients early on. And if everyone says yes and the patient consents to the cardioversion, then we will proceed with the cardioversion. And when successful, we will discharge those patients with the follow-up with the AFib clinic. The information is provided in the discharge instructions. Our pharmacist will walk over and talk to the patients and discuss the anticoagulation. If it's new onset, then they will be started on new DOAC regimen. And if the patient is already properly anticoagulated, then the pharmacist still takes the opportunity to go over the anticoagulation part of their medications and also discuss any or answer any questions on the other medications they might be taking for AFib.
Very good. And so the patients are discharged and then they follow up in 3 to 5 days in our AFib clinic. And as you suggested earlier, that was a big part of this protocol working, because if I came to the ER team and said, you know what, if you'll shock this patient and send them home, we'll try to work them in the next 3 or 4 months. And we'll do our best to see them at that, you're going to say, no, I don't feel comfortable with this. But when we could say we can guarantee a spot and follow up for all of these patients within a week, then I think that helped our ER team as they thought about the process. So at this point, I want to look at the Cone Health experience, look at the data that we have. And so Amber Seiler spent a lot of time mining our data, going through our data and looking at our patients and how they've done. And so Amber, I'm going to turn things over to you for these next few slides to talk about our experience.
Okay, awesome. So this slide is our patient demographics of folks who came in through our ER and our AFib protocol was used. And so the average age was 67, which I think in everybody's head makes a lot of sense. I mean, that's kind of the sweet spot for AFib patients. A little over half of these were female. Average CHA2DS2-VASc was right around 3. The arrhythmia breakout is really interesting though. So 28% of these patients were new onset AFib. And I think whenever we started this, we felt like most of the patients would be new onset AFib. If a patient has atrial fibrillation and is educated and anticoagulated, why would they come to the ER? But only about a third of our folks came in were new onset. 45% were paroxysmal, to Dr. Nanavati's point before, about already being anticoagulated, and that's where we chose to include them in our cardioversion consideration. And then about 23% of them were persistent, and a handful had atrial flutter. Average BMI was 30 because again we're in North Carolina, and that's just how our patients tend to be. This is the spread of age at the time of the ER visit. Again, it's a very normal histogram of ages for patients that have atrial fibrillation, and I think this makes sense to all of us, and no real surprises there. This next slide is interesting because one of the concerns whenever we started our protocol was from cardiology side. They were like, we don't want to be consulted for every patient that walks into the emergency room with atrial fibrillation. And those of us that were on this team and putting this protocol together really felt like that was not going to happen. I mean, we felt like this was a way to offload some of that work from cardiology, still ensuring the patients get really good care and they have appropriate follow-up. And so this is from our early data, probably our first 2 years of data. Cardiology was consulted 46% of the time, and a lot of that was because we were learning, still figuring out, which patients are appropriate for cardioversions, which aren't. All of this was very new to everyone on the team, and so everybody was just trying to do the right thing. And so I think the tendency was probably to call. I feel like now we don't call nearly as much as we did in those first 2 years of getting this started. Patients that were anticoagulated at discharge, 77%. Again, those were that was all comers, and so that number will not be 100% because these are patients who potentially aren't a candidate for anticoagulation or have other contraindications to anticoagulation or have a very low CHA2DS2-VASc score and weren't cardioverted. So this isn't an ER cardioversion protocol, it's an ER management protocol for patients with atrial fibrillation, and I think that's an important distinction. Our hope is to send them home from the emergency room, but that doesn't necessarily mean that they have to be cardioverted or walk out the door in sinus rhythm. As you can see, only 70% of our patients actually left the emergency room in sinus rhythm. And then 81% of our patients had follow-up within those first 30 days. And our goal clearly was to have that number much, much higher. In a couple of slides, we'll look at patients that were cardioverted in the emergency room and what their follow-up is. And I think we learned a lot of lessons from this. It's really important to capture those patients and be sure we have accurate demographic information, we have accurate phone numbers. At the end of the day, patients are sometimes our weakest link when it comes to follow-up and making sure that they come back in when we want them to. And
Yeah,
then, go ahead.
one point to make here. So before our protocol, literally 100% of our patients with AFib were getting admitted. And we can look at that. You'll show that in a minute. But so cardiology was involved literally about 100% of the time before. And so I would say, wow, we significantly reduced the consult burden for cardiology because they would have seen a lot more patients. Also, with a 3-day average length of stay, our 30-day readmission rate was a lot higher than 1%. And so, you know, to be able to send people home the same day and have a 30-day readmission rate that's that low really speaks, I think, to the overall program.
Yep, absolutely. So this next slide is really interesting. So this is from our very beginning, and it's a little bit messy, so we'll walk through it a little bit. But we started this protocol back in January of 2017, and this data goes through last month. And so the blue are patients that were discharged from the emergency room, and the burgundy line is total AFib admission. So those were all comers, and the green were percent discharged. And so what you can see is that, you know, as we got started, we were kind of hanging out, you know, 20, 30% patients that were discharged, and that gradually increased. And, you know, end of 2019, we were doing really, really well. Some months up to 50% of patients were being sent home from the emergency room. And then COVID happened. And, you know, as with everybody, our world changed drastically a year ago. And this reflects that. You know, we were trying really hard not to admit patients. We wanted to decrease exposure for patients and clinicians. Interestingly, our cardioversion numbers, which we'll look at in a little bit, really didn't change all that much, but our patient percentage that was discharged from the emergency room did. And so, and the total number of patients that were coming in did. And so I think this is just an important lesson. Also shows us that we are able to safely discharge more patients than we were in the first couple of years of our experience. And so hopefully this trend will continue. You know, our goal is, again, to send folks home. And Dr. Nanavati, I'd be interested in your thoughts on this graph and this trend, and if this resonates with what your perception was in the middle of COVID for the last year.
No, yeah, absolutely. I think our overall volume in our emergency departments, even now, is about 80% of pre-COVID. And some of it is because patients have other entry point and access point to their clinicians because of relaxation of some of the televisit regulations that came after COVID-19. And then some patients, initially at least, were just scared of coming in. So we did see patients who finally came in when they were in pulmonary edema or acute respiratory distress secondary to their AFib, and we had no choice but to admit them because they were too sick at that time. So yeah, overall volume lower for sure. Not sure why that is. Besides, I can think of is you know, they have different access points.
Yep, absolutely. So this next slide is our ED discharge volume. These are, you know, all comers of AFib. In, you know, April of 20, when COVID happened, like Dr. Nanavati said, just nobody was coming, so nobody went home either. And then, you know, I think that next spike in May really reflects where, you know, patients were probably just sicker and they'd hung on for as long as they needed to, and then they needed to come back in. So that's you know, for us, it was an interesting trend to look at. And then our cardioversion volume is also interesting, you know, kind of waxes and wanes with the months, which makes sense. I mean, our AFib volume does the same thing, and a lot of it has to do with holiday heart and, you know, holidays and, you know, people doing different things. But I think one thing over the last year that's important to remember and potentially is responsible for why our cardioversion numbers remained, you know, pretty consistent in the emergency room is because our endoscopy suite really shut down to outpatient procedures. And so if patients were seen in the AFib clinic and needed a cardioversion, well, there were no spots to put them in because, you know, we were trying to limit all of those outpatient procedures. And so a lot of patients got routed to the emergency room for cardioversion because we had proven over the last 3 years that was a safe place for them to go. They could be safely taken care of and know that they had close outpatient follow-up. And for patients that were cardioverted in the emergency room, this is their what rhythm they presented in. So 20% were new onset AFib, 52% were paroxysmal, 24% persistent, and then 4% atrial flutter. So this next slide is all of our data since we started. So we've cardioverted 385 patients in the emergency room since 2017, and that's 27% of our overall patients that came through the ER and were discharged with a primary diagnosis of atrial fibrillation. 97% of those were discharged on anticoagulation, and we would all agree that number should be 100%. I think we had some early lessons with some of our patients recognizing that chemical cardioversion and electrical cardioversion were still cardioversion, and those patients needed to be anticoagulated, and just some education around the fact that even a CHA2DS2-VASc of 0, if we're cardioverting, those patients needed to go home on anticoagulation for at least 4 weeks. 98% of the patients who were cardioverted left the emergency room in sinus rhythm. And then a much higher percent of patients came back within that 30-day follow-up window. So 92.5% of patients were seen within 30 days of discharge from the emergency room. And you know, that's really good, and that's where we wanted that to be. So for recurrent ER visits, this was, again, some of this first couple of years data, which is why the numbers don't include everyone. Folks who were more likely to come back with recurrent ER visits were going to be female and a little bit older, which makes sense in our heads. I think that, you know, we think about the little old ladies sitting at home who get really, really nervous when their heart goes out of rhythm. And I know we're going to talk about our atrial fibrillation clinic and what that looks like, and how that potentially can benefit these patients. And then the next slide talks about our length of stay in the emergency room. And as was mentioned before, there was some concern about, well, if we cardiovert these patients, then they're going to be in the emergency room longer. And I'm sure as in our system, just like most systems, that, you know, throughput is a metric, and one that, you know, is really important for the emergency room to meet. And so if patients were admitted from the emergency room to the hospital, their average length of stay was 4 hours and 51 minutes. If they were discharged from the ER but did not get a cardioversion, average length of stay was 4 hours and 33 minutes. And if they were discharged with a cardioversion, average length of stay was 2 hours and 16 minutes. And so this was just nice data for us to have and to collect, to show everyone on the team, from administrators down to folks doing this every day, that we can do this safely and quickly and not increase length of stay.
So I think that last slide really does resonate with our ER doctors, and they really did appreciate that. And along the way, what we've seen is that success breeds success, right? And so we had our initial data of about 9 months, and we sat down and we looked at that with our ER colleagues and our cardiology colleagues, and from there, things continue to improve. I've put on this slide just some benefits of an early ER discharge protocol for AFib patients, and I think we can all see that you know, patients do very well if we send them home the same day. Based on our experience, we've been able to significantly reduce hospitalizations for patients with AFib. We've been able to reduce that ER length of stay and the cost associated with that. And our hope is that by having these patients follow up in our AFib clinic, or, you know, with a provider very quickly after discharge, that hopefully we can continue that longitudinal care for that patient across the continuum within our healthcare system to try to help keep them in sinus rhythm long term. And I can tell you, patients, you know, all the time are bragging on this protocol. You know, these are patients who may have lived in other cities or may go on vacation to the beach or other places, and they find a 3-day length of stay when they have AFib, and they say, Doc, I just asked them why they couldn't cardivert me in the ER, and they weren't used to that. And so I do think that this is a great opportunity. Oh, sorry, I think I was muted for a second there. So as we continue the process, let's think about AFib management across the continuum. We want to think about, you know, putting together a center of excellence and what that looks like. And a big part of that is standardization of care to patients with atrial fibrillation. And so what we realized very early is that it takes a team. And so this picture includes some of our team. We include here our pharmacists, our ACO representatives, our cardiology team, our pharmacy team, our quality nurse, IT. You know, we've got lots of people on our team in that picture. And you can see here, you know, we include research and others as well, as we try to standardize our approach to managing patients with atrial fibrillation. This slide it comes from the Heart Rhythm Society's white paper, which was published in 2020, looking at atrial fibrillation centers of excellence. And I would encourage every one of you to pull that white paper and look at it if you're managing patients with atrial fibrillation, because you had a global team of experts looking at how to take care of atrial fibrillation patients. And you can see here in this slide that there is a continuum of care that involves lots of people, from dietitians to our pharmacists to neurology, primary care, and bariatric specialists, and lots of other folks. And as you manage atrial fibrillation, you don't want to do that in a silo. You don't want to be alone, and you do need lots of people. And so this slide is kind of our ecosystem at Cone Health of what it looks like when we take care of patients with AFib. We have our AFib clinic as the hub, and patients certainly come into our AFib clinic from the advanced heart failure clinic, from our structural clinic, from neurology with our cryptogenic stroke protocol, from our CV surgery team with postoperative atrial fibrillation patients and patients who've had Mays and mitral valve surgeries and other things. And then patients also flow out of our AFib clinic to our bariatric surgery program or our sleep apnea specialist. We partner very closely with our pharmacy team. And then, we see that roads frequently do lead to the electrophysiology lab for ablation or left atrial appendage occlusion or other things for patients. But, when we think of putting together an AFib program, the ER pathway is one part of that, but there's so many opportunities to collaborate with your colleagues to better care for patients with atrial fibrillation. And for us, we've found that working with IT to put together order sets has been effective and beneficial, and allowing us to reduce stroke and assess stroke risk, but also for education of our patients and lots of other things. And so there are many opportunities to standardize. I think our next big project is to work with our cardiovascular surgeons with postoperative atrial fibrillation. I think that's a group that we can really impact and reduce length of stay. This slide is a publication of our first year's experience with our nurse-led AFib clinic. And so patients that had been seen over a 12-month period were looked at, and we found that 538 patients were seen in our AFib clinic that first year. At that time, we had one provider, nurse practitioner, plus her nurse in the clinic. We've since expanded to 2 providers, a PA and a nurse practitioner. We have 2 nurses and 2 CMAs in the clinic. That first year, 68 cardioversions were scheduled out of the clinic. 27 patients that first year were referred for ablation, and 121 ER visits were avoided just by having those patients with close contact in our AFib clinic. So as we start to put these things together, Amber Seilers, as we start to close for today, before we go to questions, can you just talk briefly about the process of creating a comprehensive AFib program?
Yeah, absolutely. So I think everyone really wants to do AFib well, and I, like was mentioned earlier, it does take a team. This is a collaborative effort. AFib does not happen in a silo. There's so many touch points for AFib patients, and so many people that need to be included and wrapped in. And so for us, the really important first step was determining the need. Doing that baseline data collection, recognizing for our own system how many patients were admitted, what their length of stay was, what their intervention was, how many were followed up by cardiology, how many were referred to EP. And then based off of the data that's collected, really establishing goals for your center, because they are going to be different for every place. Demographics are different, social situations are different, referral patterns are different. And so those goals are going to be different. And then generating buy-in from the whole community is really, really important. Again, this can't happen in a silo, so just trying to include everyone and make sure everybody's on the same page. And then really sharing success. So I think Dr. Allred's point earlier about frequent meetings and continuing to collect that data and being sure that everyone knows this is what we've done and this is where we're going are really important steps. And so, first steps are, again, collecting those data points, really thinking about protocols for anticoagulation and how we can be sure all of our patients are anticoagulated. Thinking about utilizing and leveraging our IT resources. So creating those order sets for AFib patients that avoid IV medications, stay away from IV heparin, stay away from DILT drips, stay away from aspirin, stay away from warfarin unless there's a reason to be on that. Kind of getting patients more toward guideline directed therapy, figuring out who that core team is, and then having those early conversations, finding those cutting edge clinicians that are going to be willing to walk that journey with you and create a program that's really successful.
Thank you very much. And, it's been great to collaborate with a great team. And Dr. Nanavati, you being a team leader and helping us put together our program has been amazing. And Amber Seiler, your help with the process and logistics along the way, pulling our data, looking at things, and all the people on our team. We really are blessed to have a tremendous team of folks within our AFib program. And there's so many, it'd be hard to name them all, but we're really fortunate to the team we have. And we're thankful to be able to share this opportunity with everyone today. Thank you all for joining us on this webinar. At this point, Anastasia, I'll turn things back over to you and we'll entertain any questions that people might have.
Thanks, Dr. Allred. I'll hand it over to Jeannie Luciano, Senior Quality Programs Manager for the Get With the Guidelines AFib module here at the AHA. She'll be reading through the questions. And as stated at the beginning, please go ahead and continue submitting your questions through the question pane in the control panel. Jeannie?
Great. Okay. So thank you, Dr. Nanavati, Dr. Allred, and Amber Seiler. This was phenomenal. Really, we thank you for sharing your process for optimizing patient care, about your comprehensive and interdisciplinary approach. You've actually answered a lot of the questions as we've gone along, but one of the questions submitted was, what medications are used for ED chemical cardioversion of AFib?
I'll take that question. So we are using procainamide and flecainide most of the time, and of course we will study the indications and also the contraindications for the patient that is in front of us. But most of our patients who probably have gone through chemical cardioversion have received one of those two agents.
Great, thank you. Do these patients leave with an ambulatory cardiac monitor?
The answer is no. That's probably an area of opportunity for us, perhaps even looking at other arrhythmias that present, or patients who come in with palpitations, but by the time they're in the ER, we notice them in sinus rhythm. For our protocol patients and our AFib patients, we do not send them home with any cardiac monitoring.
And I think when we look at that, I think there are pros and cons to monitoring the patient. Trying to keep this patient out of the ER. If we've assessed anticoagulation and they're anticoagulated, and we've initiated rate control, and the symptoms are controlled, I have seen the monitors lead to increased returns to the ER and increased hospitalizations sometimes. And so early on, our plan is just to get them right back into the AFib clinic again in 3 or 4 or 5 days. To have them in front of us so that we can assess that patient. And so we haven't found that early use of a monitor has been as helpful as you might think.
And the follow-up time frame was one of the questions that's come out, so you answered that for them. How do you address the issues of ED starting an order set based on chief complaints such as shortness of breath and discovering AFib later on in the visit?
So that is something that's very common. Our patients, unless they're looking at ESI level 1 or 2 to acuity, they often will have the workup started in the triage, and then by the time EDP sees them, some of the labs have already been sent. So what we have done is we have concentrated our order set to include cardioversion specific orders in it, and that gets our clinicians buy-in especially for patients that we're cardioverting. These are the patients we want to make sure a pharmacist comes and walks over and talks to them. We get the consent. We make sure we have the right monitoring and pads on them. We start talking about procedural sedation, etc. So all of these vital things that come with the cardioversion itself is part of the order set. And so even if the labs were initiated up front, our emergency department physicians will be kind of pushed to using that order set to get everything they need at the bedside available for the patient.
Thank you. I think many of the listeners are jealous of your team. Someone wants to know, do you have a navigator that follows up with patients after ED discharge?
Yeah, it's a really good question. And I think one thing that we might not have mentioned, or if we did, I missed it, is that on that ER order set, which is really why we push to have that used, is that there's an automatic referral to the AFib clinic. And so that drops into an Epic work queue for our AFib clinic team. And so every day when they come in, they can get a list of the patients that were seen in the emergency room with a primary diagnosis of AFib or that had that order set used. And then they follow up on those patients to be sure that they do have appropriate follow-up and are seen in the right time frame. And so it's not a navigator per se to follow up on those patients, but our AFib clinic owns that responsibility of making sure that everyone that's discharged from the ER has appropriate follow-up.
Great. Do you have a social worker or discharge planner that's involved with the treatment decisions and dealing with some of the socioeconomic barriers of treatment and compliance?
So I'll start there and then maybe let Dr. Nanavati kind of follow up. I do know that we have a pharmacist in the ER who does work with the patient to make sure that they have what they need when they walk out the door and can arrive safely in the AFib clinic. And then our AFib clinic certainly does have social work access and can help patients with their care needs. Our AFib clinic has lots of experience with looking at various, for example, the DOACs and the industry being able to, if patients qualify for assistance and things like that, our AFib clinic is quickly able to help them with that. And then we're fortunate in Greensboro at Cone Health that our healthcare system has a patient care fund. Every year we're really excited about raising money in lots of different and fun ways to create money for patients who are underserved and who need assistance, and our social work and case managers within the AFib clinic have access to those funds when needed. Anka, did I leave anything out as to what you guys do directly in the ER?
No, I think, sorry, it took me a moment to figure out our resources with COVID, but yes, we have a case manager who works in our ER. They're dedicated for the emergency department. Their hours are variable, especially with COVID-19 and some of the exposures that come with it. However, we have that access in our ER for patients that we would cardiovert. We also have a coupons that our pharmacists carry for patients, and anyone who is a new onset atrial fibrillation patient who will undergo cardioversion and go home with anticoagulation, we are at least able to give them that coupon that gives them 30 days of access to DOACs. And even if we don't cardiovert them and we are still comfortable sending them home with an AFib clinic follow-up, we are giving them access to both of those resources and eventually leave it for the AFib team to pick up.
Okay, thank you. That's fantastic. So there's a question here. How do you make the decision to observe in the ED versus admission? Do you have an algorithm that you follow?
So I'm not quite clear on the question. The decision to cardiovert versus decision to admit is what I'm thinking they're asking. Is that accurate? What do you think, Dr. Allred?
Maybe.
So, as far as the cardioversion itself is concerned, I will say that we have a policy that anyone who is sedated will need to be observed an hour. And we have asked our clinicians that we use the chemical cardioversion modality, then we at least monitor those patients for 2 hours before they're discharged. If there is successful cardioversion, then they go home. If the patients return into kind of AFib with RVR and they're not safe for discharge, then of course we will start rate control and admit them.
I think
Right.
maybe the question is, are there any patients that come in and you're like, I'm not sure if they need to be admitted or if we could get by with rate control and then sending them home? Is there a thought process as to these folks for sure have to be admitted and there's, we can't sit on them for 6 hours and see if they get better, or these, yeah, maybe that's what they were, because I think like Dr. Arwood's point before, some ERs do have this observation unit where patients can go for up to 24 hours, which we do not have. And so maybe that's the distinction.
Yeah, I
Yeah,
feel
okay.
like it. I feel like it's, if they're on the fence, that's that 46% or so that they're calling cardiology on. And certainly if they're in decompensated heart failure, if they have, COPD exacerbations, as Dr. Nanavati said earlier, those patients are excluded. And so these are people who are stable, but they're in AFib and their rates might be fast. And so when I get that phone call, it's how does the patient feel? Are they a candidate for cardioversion? If so, let's do it. And if they're not a candidate for cardioversion, or even if they fail cardioversion, then that next conversation is, well, let's give them some oral diltiazem. Can we rate control them orally? Give them a couple of hours. What are their heart rates now? Okay, their heart rate's not perfect, but it's around 100 and they're feeling fine and they feel safe going home. They have good social support. They have people that, will be with them. And then it's is this someone, if I saw them in the office, would I be admitting them today? Usually the answer is no. And so those patients, because we can get them in within 3 to 5 days in our AFib clinic, we feel very comfortable letting them go home typically.
Fantastic. You actually answered a diltiazem question as well that came up. But I'm sorry, did you want to say something else, Dr. Nadavati?
No, I was just going to say my approach is if rate control, if the patient is stable and the only goal is to make sure that we have the right rate on board, I typically give them IV diltiazem followed by 30 milligram of oral diltiazem, the rapid acting, for patients who are naive to any kind of rate control medications, or they're not on beta blockers to begin with. If a patient is on beta blocker, then I typically will give them 2.5 to 5 milligram IV push followed by 25 milligrams of low pressor. We will speak with cardiology in making sure that we are sending home with some kind of advice or recommendations or change on their medication so that they don't go home and just come back to us.
Great. There's a question. Do you have a tool for predicting AFib readmissions?
We don't have a formal tool. I think that's something now that we have several years of data that we could go back through and look at. And I think that'd be a great idea.
And you may have answered this with your pharmacist, which I think is fantastic, but there's a question about how do you address patients' concerns about bleeding when prescribing anticoagulants at discharge? Are there any special education pieces that you use?
So yes, I will be using the has bled score to decide if the patient is safe to go on anticoagulation. Now, if the patient will be getting cardioversion, then, unless they have those absolute contraindications to begin with, history of brain bleeds and tumors in the brain, heavy GI bleed history, if we have those known contraindications, then we would not be approaching cardioversion without consulting our cardiology colleagues. I think my understanding is that the risk of cardioembolic event after a cardioversion is not insignificant. Probably 1 year worth of risk is undertaken within the first 2 weeks of the post-cardioversion period. So we would get our collaborative services involved. The pharmacist actually does a lot of our education piece on their behaviors and the bleeding risk and the warning signs, etc. And towards the end, at the time of discharge, the nurse and I will also walk over and make sure that all their questions have been answered before they leave our department.
Thank you so much. I'm going to hand it back to you, Anastasia. Thank you for all the wonderful answers and clarifications for our listeners.
Thank you to our presenters today from Cone Health, and thank you to everyone for attending today's webinar. Once you leave today's session, you'll receive a survey, and we would appreciate it if you take a moment to complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's session. On behalf of the American Heart Association and our presenters, thank you for joining us today and have a great rest of your day.